Hello, Rotarians. It is my pleasure to introduce today our President-elect, Steve McConnell. He has been a leading expert in software estimation, software measurement, and software engineer practices for more than 20 years. He is best known as the author of the software industry classics, Code Complete, Software Estimation, Demystifying the Block Art, and More Effective Agile. And he's also the CEO of Construx Software. During the early stages of the pandemic in the United States, Steve joined a group of experts to discuss data on the effects and developments of the virus. This discussion led him to join another group of elite researchers, including scientists from Harvard, MIT, IHME from the University of Washington, and he's currently contributing to the CDC's COVID-19 Ensemble Forecast Model. Steve's models show how the virus is spreading in the United States, both at the national and at the state level. His models also have served as a point of reference for comparison with other models, some that are highly publicized, that are being used in the media, and contain a significant amount of inaccurate information, which can cause unnecessary fears in our communities. So I leave you with our very own Steve McConnell.
All right, thank you, Luisa. If my screen is not sharing, I hope somebody can say that my screen is not sharing. I see thumbs up if you can see the screen. Great, thank you. So the focus of the talk is on inside look at COVID-19 forecasting. We only have 20, 25 minutes, but so hopefully my goals aren't too ambitious. I'd like to try to demystify forecasting a little bit, take a little bit less of an emotional or political approach to the topic and spend more time just looking at the numbers. And I want to acknowledge this can be a difficult chore for people to get into that mindset. It is an inherently emotional topic because it's so important and there's human life at stake. An interesting experience with my daughter where I was working on some spreadsheets and graphs and so on, and my daughter's very mathematically oriented. She's 23, and I was sharing with her what I was doing, and she said, I think I would like doing this if it wasn't on this topic, but because it's this topic, I can't just see the numbers as numbers. To me, they all look like humans. And so I think that I just want to acknowledge that I know that some people do come from that frame of reference. For me personally, I really am able to see them as numbers. And for me, I think this activity has been a good source of just a way to keep busy and stay constructive during the pandemic. So I want to try to diffuse the emotion politics a bit, provide some background on the CDC's forecasting process, talk a little bit about what's possible and what's not with forecasting, give you a little bit of a view of what the state of the art currently is with forecasting. And my ulterior motive in the talk is to show why you should ignore the IHME's forecasts, which I think are not well founded and have done a lot of damage. And if you think I'm just spouting off on that, you'll see momentarily that there's some reason for that. So why would we bother to forecast a pandemic? I think we should look at both the state and the national picture. At the state level, state forecasts are used to guide near-term activity planning and event planning, even things like whether people can plan weddings or that kind of thing, or how many people they might be able to plan to attend. At the public policy level, it helps to anticipate regional surges that individual regions are going to have difficulty addressing on their own. So it says who's going to need help, but also helps to identify areas that are not expected to have surges and that might be able to spare supplies or equipment or staff. Early in the pandemic, Washington State sent a bunch of ventilators to New York because we believe that New York was in a more serious situation than we were. So that's the kind of thing that we can do with local or state level forecasts. There's also this general idea that forecasting provides data-based feedback on policy decisions. And this is a bit of a double-edged sword. If we can keep the forecasting and the data analysis used in the forecasting separated from our beliefs about the policies and the assumptions, then it can provide that kind of feedback. But a lot of the forecast models end up just baking the assumptions that they're trying to test into the model itself, and then that just amounts to assuming what you're trying to prove, and that doesn't really work. At the national level, we also use forecasts to guide near-term activity and event planning on a 1 to 4 week horizon. It provides important context for the state level forecast. It's relevant whether if an individual state or a handful of states are kind of exploding in terms of the pandemic, how much excess capacity do we expect to have at the national level? That's a relevant consideration. If the whole country is going to be overloaded, that's one thing. If it's just an individual region or two or three, and the rest of the country can pitch in, then that's a different circumstance. It's useful to know that. We get the same kind of database feedback if we're careful about how we treat it. And then I think also the right kind of forecasting can help us to avoid panic. There's no question that this is a really serious situation, but we'd like not to think it's 10 times as serious as it is. And I think in some cases the forecasts have been used to create panic, which I think is not helpful. The political agenda, in some cases just a policy agenda, I think has been pretty counterproductive and is part of what got me interested in this in the first place. So I guess before getting further into the topic, I should explain what my personal role is in this. My role today is not speaking to you as incoming Rotary president. My role to you today is not speaking as author of a bunch of software books. My role today is speaking to you as the lead of the COVID complete forecasting model, which is being used in the CDC's ensemble forecast model. I have a long-standing interest in estimation. I published the software estimation book in 2006. I am best known as the author of a detailed software coding practices book, but my interest in estimation actually predates my interest in the topic of my main book, Code Complete. So to me, this is kind of where it all started. And one of the things I found in software estimation, this is a quote from a study that I cite in my book, is that experts tend to use simple estimation strategies even when their level of expertise in the subject they're estimating is high. And we have a lot of estimates or forecasts that are created by subject matter experts. We kind of assume if they're an expert in the subject, they'll be an expert in making forecasts on the subject, and that's not really true. If they're subject matter experts, they can still use even primitive estimation practices that for someone who knows what they're doing on the estimation front are just obviously flawed. And so subject matter expertise does not guarantee estimation expertise. And I don't really bring any subject matter expertise to this particular topic, but I bring a lot of estimation expertise. And so that's really what I'm trading on. So if you go to the CDC website and you look at the COVID-19 forecast for deaths, and you scroll down a little bit to the diagram that shows all the models contributing to the national forecast, and you zoom in on the model and you see the one called COVID Complete, that's my forecast model. And for last week, this is what my forecast looked like. You can see there's huge variation in the forecasts that are being submitted. I'll talk about that a little bit more in a few minutes. Why did I get involved in this specific issue? I like estimation, I like forecasting, I like predicting. Pandemic's obviously on the top of everyone's minds right now, but why did I actually go to as much trouble as I've gone to? It's because I really don't like playing games with forecasts during a pandemic. I really like accurate information. At a personal level, I just wanted to know what was going on. And I was having a hard time understanding what was going on because there was so much conspicuous manipulation of the data that was being presented. And to give you a couple examples, from early in the pandemic, this was a chart that was presented in Washington State presentation at the end of April. So this was the end of April right here when this data was presented. Now, the first problem with this chart is, why is there no data for the 2 weeks preceding this? The data was readily available. I could go look it up on the internet as a private individual. So why isn't this data there? That bugs me for starters. The second issue is, this green line going through the middle of the graph is described as the expectation, or statistically the expected value. And the expected value is supposed to be in the middle of the probability distribution. So what's going on with these points? Above the line, we've got 2 points. Below the line, we've got 38 points. And so somebody's trying to do something with the data here, because they're not actually putting the expected value line through the middle of the points like they should. And this just bugs me. People are, I don't care if they say, look, this is the 95th percentile line, and then they present it accurately. But it really bothers me when somebody says, this is the nominal case, And it clearly, from what the data that's presented, is not even close to the nominal case. That says basically people are trying to manipulate me with data, and I don't like that. And then I think in terms of forecasting, we get these points out on the right side that I've marked with the 4s. And this basically says we have no idea what's going to go on, what's going to happen. It could go up a lot, it could go down a lot, it could stay the same. Well, I don't really need a graph to say we don't know what's going to happen. I think we could just say, you know, our field of vision ends here and we can't make forecasts beyond that. So that's from back around May 1st. More recently, we've had the IHME, which I'll talk about a little bit, making forecasts like this. This came out published on September 4th, or rather updated September 6th. And so the IHME came out with this forecast that said there are going to be 410,000 US deaths by January 1st. And this is described in news sources as a key coronavirus forecast. It's not just a forecast, it's a key forecast. In other words, one that they're sort of implying we should take seriously and rely on. And so in the body of the article, this is described as a most likely scenario. They actually thought we might incur as many as 600,000 deaths by January 1st, but their so-called most likely scenario is 410,000 people dying between September 6th and January 1st. Well, how did this forecast work out? So, well, let's start first by taking a look at what would need to happen for this to be true. Now, back in May, I hadn't been paying a huge amount of attention to all this stuff, and I didn't really understand the data very well. But by the time we got to September 6th, I was contributing forecasts to the CDC and was deeply involved in the data. So what would have to happen for this to be true? Well, number one, the death trend would need to more than double immediately, despite the fact that the trend had been going in the opposite direction for a few weeks. It had been going down 10% per week. For the IHME forecast to be true, it would have to suddenly more than double and stay that way for the next 4 months. Number two, we need to incur more deaths in 4 months than we've had since the beginning of the pandemic. So, you know, initially the pandemic caught us by surprise. There's a reason we reacted kind of, you know, initially slowly and ineffectively, but we're not in the same situation anymore. The idea that we're going to have more deaths in 4 months than we've had since the beginning of the year seems pretty implausible. We also need to average 1,800 deaths per day for 115 days straight, which is 100 more days than we've had that number of deaths so far in the pandemic. So we're going to be hitting new records on a daily basis. And no one can take any corrective action to reduce the deaths, even after the deaths skyrocket. And they have to continue not to take any corrective action for 4 months. So from my point of view, this forecast was completely unfounded. It's baseless. And I would make two observations. Number one, this is not going to happen, basically for the reasons I just said. And number two, it certainly isn't most likely. There might be some scenario where everyone falls asleep for 4 months and lets this happen, but boy, that sure doesn't seem most likely to me. So by now it's way past September 6th, and we can actually know what happened. In this forecast, their projections are reported on September 6th. They also included what's called a 95% prediction interval, which means that's supposed to account for 95% of possible outcomes. There should only be a 5% chance of being outside on either side. So 2.5% chance of being low, 2.5% chance of being high. Well, guess what? By 3 weeks later, by September 20th, reality, the yellow line, was already outside of IHME's 95% prediction interval. And that's just not supposed to happen. And if it does, it should happen only rarely, you know, less than 5% or about 5% of the time. So just completely unfounded. And I think that what we see is reality had disproved IHME's forecasts. Now, if forecasting in this era, in this particular time frame was difficult, maybe we could cut IHME some slack, but there were other groups that were doing vastly better over this same period. So this is a chart that shows the full set of national forecasts submitted to the CDC for that same time period. The best forecast had an error of 0.2% for the 4-week period. All right, 0.2%. The ensemble forecast, which is the forecast of record for the CDC, had an error of 8.2%. For the sake of, or rather, no, I'm sorry, that's mistitled. That error of 5%. My model, which was not the best, had an error of 8.2%. And way over here on the right, IHME is 27th out of 33 models. They had error of 31%. So the best model had error of 0.2%. IHME had error of 31%. So as I said, one of my not so hidden agendas in this talk is to get you to ignore IHME's forecast. They get a lot of exposure, completely out of balance with the quality and accuracy of their forecasts. So to summarize, why did I get involved? I just wanted to know what was going on with the pandemic without all the spin. So let's turn then to, I'm trying to watch my time here. Let's turn then to the CDC COVID-19 forecasting. I'll make the slides available to anyone who wants them, and there are lots of links in the slides. So if you want to follow up on anything, it's pretty easy to click through the links. And so the CDC forecast work is headed by a team at the University of Massachusetts Amherst. It's an organization called Reich Labs, and they're in the Department of Biostatistics and Epidemiology. The way they work is modeling groups submit forecasts to the team at Reich Labs, and then the forecasts that meet certain criteria are combined into the ensemble model, so-called, which is the forecast model of record for the CDC. Forecasts are submitted weekly on Mondays, and they are for the forecasting period that starts the day before. So the forecasts that were submitted yesterday started on Sunday 2 days ago. Forecasts are submitted via GitHub, and there are probably 5 people in the club who know what that is. But what it really means is that all forecast data is public info, and anybody who wants to can go look at it. So if you really got interested, you could go look at all the detailed forecasts that have been submitted right now. The forecasts are submitted in the form of CSV files, that's comma separated value files, with some specific formatting requirements. And to submit a forecast into the ensemble model requires that you generate about 10,000 forecast records per week, per team to participate. So that's what I'm doing every week, is I'm generating these 10,000 forecast records that gets my COVID complete model included in the ensemble forecast. So the forecasts are for a variety of things. They include point forecasts, which is the most likely number. If you hear one number cited as a forecast, that's the point forecast. Then it also includes prediction interval forecasts. Prediction interval is the correct name for this kind of forecast. You often hear them called 95% confidence ranges. That's not actually the correct terminology, but the gist is more or less the same. So you submit both kinds of numbers into the CDC forecasting system. Some teams submit forecasts for cases, that is a forecast of how many people are going to test positive. And some teams submit forecasts for deaths, some submit forecasts for both. I'm only submitting deaths forecasts, and so that's what I'm talking about this afternoon. Forecasts are submitted for 51 states, and some teams also submit forecasts for territories, Guam, US Virgin Islands, and so on, and then also for the US national region, and then for time periods of 1, 2, 3, and 4 weeks out. So by the time you do all the permutations on this, the points, the intervals, the time periods, the regions, that's how you end up getting 10,000 records submitted to the CDC per week. The forecast teams are from all over the place. They come from universities, research labs, and individuals. The university teams are for some pretty well-respected, well-known institutions, including Carnegie Mellon, Harvard, Georgia Tech, Johns Hopkins, UCLA, USC, University of Geneva, University of Texas at Austin, MIT, London School of Hygiene and Tropical Medicine. Really a lot of really well-known names here. Research labs are probably not as well known, and then there are a bunch of individuals that are also mostly, well, I'd say entirely not very well known, except for maybe their work on forecasting. Yuyang Gu has been consistently one of the better forecasters, and that's probably the highest profile individual that's been involved in this. So in total, there are about 30 groups submitting forecasts into the death forecasts. Interestingly enough, the better forecast teams and the worst are not what you'd expect them to be, especially considering the reputations of some of the institutions involved. One of the things you do when you start submitting forecasts to the CDC is you get to participate in a weekly forecasting call, which is Tuesdays at noon Pacific time, and you review the week's forecasts. what I've seen is that the university teams can be awfully academic. They can be more interested in basically teaching a grad student how to do machine learning or artificial intelligence than they are in getting an accurate forecast. And you'll see that when we look at some of the results in a couple of minutes. What's amazing to me is that the ensemble model, which is a combination of all these forecasts, is actually surprisingly accurate considering the inaccuracy of a lot of the forecasts that are that feed into it. And I do think there's an aspect of you're probably better off just not knowing how the sausage is made. There's a lot of well, it's nowhere near the level of rigor that you would expect for a topic of this importance. And I think one of the issues here is that forecasting is not the same as speculation, but we kind of end up, some teams end up confusing the two, and the media ends up reporting speculation, I think, more than it reports forecasting. We had kind of an extraordinary thing happen in the middle of September, which is that Nicholas Reich, who's the head of Reich Labs that oversees the ensemble model, published an article in the Washington Post expressly critical of IHME, which is one of the organizations submitting forecasts into the ensemble model. And his point really was that if we're trying to forecast more than 4 weeks out, we do not have data or methods that can make forecasts more than 4 weeks out. We're really just speculating. And we would love to make longer term forecasts. There would be a lot of value in that. It would be really important and useful if we could do that. But the fact that we need it and it's important doesn't mean that it's possible, unfortunately. And yet some organizations are treating it as though it is. So basically, Nicholas Reich's comment is anything further out than 4 weeks is speculation. Even if you dress it up with graphs and numbers, which it always is, it's still speculation and it needs to be interpreted as such. So the difference really is in forecasting, we know the inputs and we calculate the outputs based on known relationships among the inputs. When we speculate, the inputs are guesses and the outputs are basically just guesses piled on top of other guesses. So you could think of it as knowns and unknowns. If we're forecasting with knowns, we can know the number of people who have already tested positive. We can know the approximate relationship between positive tests and cases. We can know the approximate fatality rates by age and comorbidity status. And we can know how the virus progresses in individuals and over what kind of timeline. So that allows us to make meaningful forecasts in that 1 to 4 week range. And the unknowns, the speculations include what specific policies are going to be implemented in states, the degree to which the policies will be followed or not followed, the effectiveness of policies that haven't been tried yet, the effectiveness of policies with whatever level of compliance we're actually able to obtain, when vaccines might be available, how effective they'll be when and if they become available. So you can see this is basically just piling one unknown on top of another, and we just end up with a big chain of unknowns that collectively tells us very little or is just extremely unreliable about what might happen in the future. So the basis of forecasting is what we know. What do we know? Well, we know that the fatality of COVID-19 is strongly age-related. We know that it's strongly comorbidity-related. We know that a huge number of people have actually been infected, far more than have been tested positive. Early in the pandemic, when we had minimal testing, we had probably on the order of 10 to 20 actual cases or infections per positive test. Now we have on the order of 3 to 5 infections or cases per positive test. So these are some things we know. And we also know the timing of the course of the disease. I'll just include these charts here for your reference if anybody wants the materials later. And there's also, I think, some really interesting and good data for anyone who really wants to understand the relationship between comorbidity and the risk factor that you incur. The CDC has some really interesting and useful information on specific comorbidities and how well documented or how well researched the effect on your risk factor is, the URLs on the slide. So we have a pretty good view of the timing of the disease at this point. And so we know, obviously, somebody gets infected. At some point, they become contagious. At some point, they show symptoms. Maybe we know that lots of people don't show symptoms with this disease. Then they get tested. At some point, contagiousness ends. At some later point, if they get really sick, they die. And if they don't get sick enough to die, then at some point they develop antibodies. And we know the approximate timeline of how this occurs. One of the things that's happened over the course of the pandemic is that testing gets pushed earlier and earlier. The goal here really is to push testing so that it precedes the time that contagiousness begins. So if we can get good contact tracing in place, then we could realize the ultimate goal here, which is to get the vast majority of people tested after they've come in contact with an infectious person, but before they themselves become contagious. We're not there yet, but in the data, you can see that we've been moving that direction for months now. Of course, there's variability in all this. People don't become contagious exactly 2¼ days after they get infected or develop symptoms exactly 4½ days. There are probability distributions around each of these numbers, but for forecasting purposes, that doesn't actually matter that much. If we know where the center of the distribution is, then we can make use of that. So, for example, we know the period from infection to death averages about 18 days. That's useful to know. We know the period from infection to antibodies averages about 21 days. That's useful to know. We know contagiousness lasts about 9 days, and there's definitely some different schools of thought on that, but somewhere in the range of 7 to 9 days. And we know the period from test to death has been 12 to 14 days. That period has been extending over the course of the pandemic because we've been pushing testing earlier in the cycle. And that's actually a good thing. Makes forecasting interesting because the relationship changes. The timeline has changed over time, but it's still a good thing overall. It's also good to keep in mind that this is really about reporting dates, not actual dates. The relationship between the test is really the date the test is reported. The relationship to the death is really the date that the death is reported. So a lot of what we're looking at is not the actual phenomenon, it's the phenomenon of what gets reported, and that needs to be accounted for too. And I'm not going to get into that too much today. So what does all this have to do with forecasting? Well, it says if we want to deal with knowns, we can take the number of people who test positive. So that's something we know. We know that we've learned that it takes about 14 days for some percentage of those people to get sick enough to be hospitalized and die. And we can therefore forecast the number of deaths 14 days ahead. At least that's the approach that I take. And we can do this with really, really good accuracy at the national level. And we can do it with fair accuracy at the state level. And because trends tend to continue forward, we can project that forward for another 14 days beyond that, essentially based on the assumption that the next 14 days are going to look pretty much like the preceding 14 days for any given combination of 14-day periods. Other groups use different methods. Some use massive data sets like 500 million records, literally. We have some use of esoteric data like mobility data from cell phones. We have machine learning and AI and statistical practices like Bayesian analysis and Monte Carlo simulations. I think one of the really interesting aspects of forecasting has been that the more mature, established labs had pre-existing pandemic models, especially related to influenza. And I think that actually put them at a disadvantage because a lot of the assumptions in their influenza forecasting models just didn't apply. And so it took them a period of months to strip away all the assumptions that were different. In a lot of ways, it was easier to start from scratch than it was to start with a pre-existing forecasting model that didn't really apply. I like this quote from J. Scott Armstrong in his book, Principles of Forecasting. I included this in my estimation book. He says, one of the most enduring and useful conclusions from research on forecasting is that simple methods are generally as accurate as complex methods. And I think that's a useful insight too. People tend to think the more elaborate the method is, the more accurate it's going to be, and that's really not the case. Okay, so let's take a look at what's possible with forecasting nationally and at the state level. For the 1 week period that ended on Saturday, which is the end of the most recent period, the national forecast, the best forecast was off by 1%, the ensemble model was off by 5%. So, and we had more than half the models within 10%. So that's pretty good, really. For the 2 week period that ended on Saturday, the best model had effectively 0 error. The ensemble model had 2% error. Again, we had more than half the models that were within 10%. So really good accuracies possible at the national level. For the 3-week period, the best model was off by 2%. The ensemble model was off by 9%. This was actually a more challenging period for some reason, so we didn't have as many models that were within 10%, but we still had quite a few. And then for the 4-week period that ended Saturday, my model was actually the most accurate. For this 4-week period, my forecast was off by 2, and the ensemble model was off by 4%. IHME was off by 6,060. Okay, so just to kind of put a fine point on IHME, I was off by 2, they were off by 6,060. They tend to be in the bottom of the pack here in terms of accuracy. So here's a chart that just shows the accuracy over time for 1, 2, 3, and 4-week forecasts. Individual periods tell you something, but this is the aggregate results over the full set of forecasts from August 3rd to September 28th. The ensemble model leads the pack, which is great. It should. Their average error was 4%. They had 93% of their forecasts within 10% of the actual value. So this is really, really good accuracy for national forecasts. My model had an average error of 6%. I had 83% of forecasts within 10%. And IHME is way back here where their average error was 20%. They only had 17% of forecasts within 10%. So if you wonder why I'm critical of IHME, look at the contrast. Ensemble model, 93% within 10%, IHME, 17% within 10%. I don't know why anyone's still listening to these guys. The other point I'll make briefly here is that the national forecasts have improved a lot since July. If you were looking at forecasts in July and thought they were off by a lot, they were, but they've actually improved substantially. August got a lot better, September is getting better again. There's more information on my website. You can check that out if you're interested. State forecasting, I'll basically just say, it's a bit more challenging because the numbers of total tests, positive tests, cases, and deaths are smaller. The data is rougher. States have all kinds of issues related to how they report the data. And the models tend to do better on states with bigger numbers. The unfortunate thing here is that I think accurate forecasting is arguably more important at the state level than the national forecasts are, because it tells us where we need to actually provide some extra assistance. So just to kind of very briefly show you some examples here, some of the bigger states, like for this particular period, the 2-week period that ended on Saturday, the forecasts for Texas were pretty good. The ensemble model was off by 3%. For California, pretty good. The ensemble model was off by 1%. For Florida, some of the models were pretty good. The ensemble model was off by 16%. So, the bigger states can be forecast pretty accurately by most of the models. The smaller states are more problematic. So Delaware, for example, no model was really that good. We only had one model that was within 10%. I think that was basically an accident. The ensemble model is way out here with 100% error. Missouri, same thing. Missouri's been kind of problematic. The ensemble model, again, has an error of about 100%. North Dakota, for this period, was problematic. The best forecast was 30% off. Ensemble model's off by more than 100%. So we get kind of a mixed bag in terms of the state forecasts. And, in a good period, the best models for any given period tend to get about half of their forecasts within 25% of actual. And so the state forecasts are a little bit more challenging, quite a bit more challenging than the national forecast. And again, there's more information on this on my website if you're interested. I've got scorecards that you can use to see which models are consistently more accurate. And I'll just summarize by saying, hopefully you've seen that accurate forecasts are possible on 1 to 4 week basis. Certainly at the national level, national forecasts have become more accurate over time. State forecasts have also become more accurate over time, but they're still nowhere near where the accuracy of the national forecasts. And the interesting thing is the most accurate forecasts are coming as much from private individuals as they are from universities. If you were looking at those graphs as I was going through them quickly, you see some really, really high profile institutions on the far right of those at the low accuracy point, where you've got University of Washington, MIT, Johns Hopkins, and so on. These groups you'd think would be producing really accurate forecasts, and some of them just are not. And I think the overall really good news here is that the CDC's ensemble model is consistently among the most accurate forecast models for nearly all periods and all types of forecasts. And I think that's as it should be, right? The model of record is actually pretty accurate. So I think anyone who wants to can request the slides. There are a bunch of links in the slides, and I think we're about out of time, so I will turn the mic back over to Tom, and he can tell me if we want to take time for questions or if we need to wrap up.
Thanks, Steve. That was really informative. Camera for me. Good. Thanks, Steve, for a really informative presentation. We appreciate you spending the time to put all that together for us. Just a couple of quick questions, and then if you can hang around afterwards and talk to any who have questions, that would be great. A question that was on the minds of several was, what is comorbidity?
Yeah, so comorbidity refers to the physicians in the group will correct me on this, but in the COVID-19 context, comorbidity usually refers to the existence of a pre-existing condition and the effect that that has on your risk. And according to the CDC, the biggest comorbidities as far as COVID-19 is concerned are serious heart conditions, cancer, chronic kidney disease, COPD, really high obesity, sickle cell disease, solid organ transplantation, and type 2 diabetes. And again, I direct you to the CDC website, which has good information on what the more serious pre-existing conditions are. And this is important because the risk factor is tremendously different if you have any of these pre-existing conditions versus if you don't.
Great. We'll wrap it up here, Steve. And then again, if you could hang around for a few minutes, that would be great. By the way, I don't have a camera on, but I'm still here. You can hear me, hopefully. So thanks again for a great presentation. Steve, wanted to let you know, you know this already, that we do have a speaker's gift that is presented in your honor, 1,500 pounds of food that goes to local food banks in our community. Thank you again for that great presentation. Next week's program is Carol Kessler, who will talk about our systems and redundancy. Are our systems and redundancies simply not good enough to manage nuclear risk? So that should be an interesting presentation as well.